Hello, this is Dave Nichols coming to you from Seattle to present on the topic studies testing the drug-drug interaction between azithromycin and tobramycin. I want to thank the committee who organized the meeting this year for the invitation to present on this topic. Some of you know it's been a focus of part of my research for several years, and we're grateful for the chance to give an update and present the results of the trial. Way of disclosures, I acknowledge grants and some consultation work I do largely at the TDN Coordinating Center. So today I want to quickly review the non-human research studies that have been done looking at this question of a drug interaction, and then review the post-hoc data analyses that have been done in people with CF, both in clinical trials data and also some clinical databases. And then spend most of the time presenting the top-level results of the TEACH trial, which was a prospective randomized controlled clinical trial focused on this question of an interaction between azithromycin and inhaled tobramycin. So let's summarize the non-human research. And I've provided the references for those who are more interested. Encourage you to pull those out and read them in more detail. But in brief, adding azithromycin reduced the effectiveness of tobramycin when delivered systemically in a mouse model of Pseudomonas-infected burn wounds, eliminated Pseudomonas killing with tobramycin in a model of mature biofilms of CF Pseudomonas isolates, eliminated Pseudomonas killing with tobramycin in a stationary phase assay, noted to have 50% antagonism in a number of isolates from people with CF when tested in a flow cell biofilm culture model. That antagonism was not seen when azithromycin was tested in the same conditions. And azithromycin was found to be additive or beneficial when added in combination with colistin and levofloxacin, neutral with amikacin, but antagonistic with tobramycin in another model of non-surface attached biofilms using a number of CF isolates. There have been some unpublished data, largely from the Manoil Lab at the University of Washington with the work of Sam Lee. And I'll just summarize that for you here. Because it's unpublished, I'll show you a couple of those assays, but a range of different culture conditions in which they find antagonism consistently between this macrolide and tobramycin in vitro. So these are some representative data of a model of late stationary phase growth. It might be termed a bacterial tolerance or antibiotic tolerance assay. We're looking at time-dependent killing across the x-axis on the bottom, and then log-fold changes. Here we see a 4 log-fold change on the y-axis. So you can see with tobramycin alone, there's significant time-dependent killing of Pseudomonas in this assay. But when you test azithromycin alone or the combination of azithromycin and tobramycin at the same concentrations, you see really no difference compared with no drug therapy at the top. Basically, killing is eliminated in that model. A similar model where stationary phase growth occurs in the test tube and then antibiotics are added for a 5-hour exposure. And then this is plated onto a rich agar. So this would be the control where you have serial dilutions going from top to bottom. And then from left to right in the columns, you have either no antibiotics and then increasing concentrations of tobramycin where you see that nice dose-dependent killing effect. When the same tobramycin concentrations are tested, but azithromycin is added to that 5 hours of antibiotic exposure, that killing is basically eliminated in this model. So the summary of the non-human research finds that azithromycin selectively reduces the ability of tobramycin to prevent growth or kill Pseudomonas across several culture models and when tested in both lab and CF clinical isolates. Let's move then to some post-hoc analyses of data from human studies. The first, inhaled azithromycin versus tobramycin trial, also called the active comparator trial. In this, azithromycin users, by self-report, had on average no real improvement in lung function across 1 or 3 of the 4-week cycles of inhaled tobramycin. They also had a greater need for additional antibiotics. In the AIR-CF2 trial, again looking back at those data, those who were reporting azithromycin use as a concomitant medication They had significantly better improvement in their lung function and their respiratory symptom score during a 4 weeks period of inhaled aztreonam. And that was better than was seen in the 4 weeks run-in period with inhaled tobramycin. Those not reporting azithromycin use had improvement in both periods of antibiotics. In a clinical database looking at adults who were being treated for acute pulmonary exacerbation, those who were on azithromycin had an association with more favorable response to IV calistamethate, but had a less favorable response when treated with IV tobramycin in regards to FEV1. And in children from Canada experiencing acute exacerbation, again, azithromycin use associated with less favorable response in regards to FEV1 improvement to IV tobramycin. An analysis of the USCF National Patient Registry found that azithromycin use associated with a slower rate of decline in FEV1 over a period of years in those who were infected with Pseudomonas aeruginosa. But this apparent benefit from azithromycin was significantly diminished in users of inhaled tobramycin alone, and that wasn't diminished in those who were using inhaled aztreonam alone. So the references are provided there for those who would like to dig a little deeper. But to summarize, when considering tobramycin as chronic inhaled therapy or an acute IV intervention for exacerbation, azithromycin users had less improvement in lung function compared with those not using azithromycin. It's very important, though, to remember that these post-hoc analyses are susceptible to unmeasured confounding. And more specifically here, there may be indication bias, whereby azithromycin users are not like non-azithromycin users, and the numerous statistical models that have been applied to these studies may not have fully been able to account for those differences. So in other words, assessing causality is very difficult to impossible in these retrospective analyses, which is why we need, when possible, to conduct prospective studies, and that was what was done. So the TEACH trial, testing the effect of adding chronic azithromycin to inhaled tobramycin, is a study conducted here in the TDN and just completed here in the last year or so. In brief, the key inclusion-exclusion criteria, we assess people aged 12 years and older who had 2 or more PA-positive respiratory cultures within the last year. Their baseline lung function was 25 to 100% in regards to FEV1, and they were otherwise stable. We wanted to enroll the clinical paradigm of chronic inhaled tobramycin users. We required them to use at least 2 of their 4-week cycles in the last 24 weeks. And they did not need to be using azithromycin at the time of enrollment, but they had to have tolerated chronic azithromycin in the past. Turned out over 80% of people came into the study using chronic azithromycin. They couldn't have had recent antibiotics or used higher doses of systemic corticosteroids regularly, and we did not include those with recent B-Cepacia complex or NTM positive cultures. Our primary outcome was looking at the clinical consequence of the relative change in FEV1 in liters from randomization to the end of a single 4-week period of their inhaled tobramycin. We also looked at just the 4-week period during inhaled tobramycin. I'll explain that a little more in a moment. And then some of the other secondary outcomes. Obviously, this work is based largely on bacterial findings or microbiology. And so we looked at sputum Pseudomonas density, although we were concerned that we may not get enough samples. And so that was not necessarily prioritized in this study as an outcome. The results are fairly interesting. I'll show you those in a moment, though. We looked at change in percent predicted FEV1 rather than the relative change in volume. We looked at symptoms, need for antibiotics, and some other related safety measures. So this is how the study was designed. Participants came in on their usual care, which was off of their inhaled tobramycin. Note that they could not be cycling between multiple inhaled antibiotics. They needed to be off of all inhaled antibiotics at that point. And then they were randomized in a blinded way to azithromycin or placebo that they continued for 2 weeks before they started their inhaled tobramycin cycle of 4 weeks. I'm going to focus today on the randomized controlled portion of this, which is a 6-week period from randomization where they started azithromycin or placebo to the end of that 4-week period of inhaled tobramycin. So what did we hypothesize would occur in TEACH based on what we had seen in vitro and some of the post-hoc analyses? It was this, that lung function would not be much different over that 2-week period where they're starting azithromycin or placebo. But then during the inhaled tobramycin portion, those on azithromycin wouldn't have much improvement, but those who are off azithromycin through placebo would have a significantly greater improvement in their FEV1. And again, based on the microbiology, we had hypothesized that the Pseudomonas density in sputum samples would not change much in that group on azithromycin, but we would see a decrease in Pseudomonas density in that group who were on placebo, where the azithromycin was not present. Give you a little bit of information on who we analyzed. This is the modified intent to treat population. You can see we included about 60 people in each group. They're a little over 60% homozygous for F508del, but this was conducted really prior to the introduction of the Alexacaftor, Tezacaftor, Ivacaftor into clinical use. They're based on lung function, right at 70% of predicted in regards to FEV1. About half and half were using inhaled tobramycin solution or powder, and they continued on their own prescribed inhaled tobramycin product. And as mentioned, over 80% were using chronic azithromycin at enrollment. So what did we find? Well, the primary endpoint focusing on the relative change in FEV1 in liters is this. We observed really no significant or statistically significant difference between the two groups, 3.44%. However, the trends were not as we predicted, as I showed you a moment ago. The placebo group did not show a greater improvement in FEV1, particularly during that inhaled tobramycin period or across the 6 weeks. Here's something that may be a little more intuitive to understand for those familiar with spirometry. This is the absolute change in FEV1% predicted, which is more commonly used in trials these days. And you can see that there's virtually no change in those in the azithromycin arm and a small decline in the placebo group. So this difference was not statistically significant across the 6 weeks, which was the primary focus. It was even smaller across the 4-week period during inhaled tobramycin. It's worth mentioning that a lot of these people in the placebo arm were on azithromycin, and so there's some rationale or question as to whether this slight decline is actually the removal of azithromycin. It's hard to understand why they would do worse on inhaled tobramycin based on the prior data, but that is one hypothesis, is that we're seeing some modest decline with functional withdrawal of azithromycin in most of those people. What did we see in Pseudomonas density in the sputum? This is where it gets fairly interesting for those people like me interested in Pseudomonas biology. And so I want to call out at the bottom, the fewer participants were able to provide us these matched sputum samples at both time points before and after to assess for a change in density. About 60% of the population overall provided some data to the Pseudomonas outcome. We did see a statistically significant difference here, whereby those without azithromycin, so those in the placebo arm, had a greater reduction in their Pseudomonas density across the 6 weeks. It's about 0.75 log, 10 units difference between the two groups. If we consider that subgroup who came in on current azithromycin use on enrollment, that difference was a little bit larger. Just to briefly mention other secondary outcomes, we did not see any significant difference in self-reported respiratory symptoms, severe adverse events, exacerbation events, need for additional antibiotics, and ECGs were measured during the study, and in no group and did we find QTc prolongation events. So what can we take from the TEACH trial? Well, we can say that in long-standing users of inhaled tobramycin, concomitant azithromycin does not reduce the short-term impact on lung function. Any effects on long-term outcomes, such as a rate of decline in lung function or risk of exacerbation, were not the focus of this study and so can't be addressed by these data. In this study population, Little change in FEV1 was seen during a 4-week cycle of inhaled tobramycin therapy, and that was regardless of azithromycin use. And this was despite a greater improvement in the sputum Pseudomonas density in the absence of azithromycin, which is consistent with the antagonism that's been observed in vitro and kind of sets up a disconnect between this change in microbiology and change in lung function in those who are longtime users of inhaled tobramycin as a product. So let's summarize overall. What we can say is that in vitro and in animal models, azithromycin selectively reduces the antimicrobial effects of tobramycin against Pseudomonas aeruginosa. In post-hoc analyses of data with people with, data from people with CF, using both azithromycin and inhaled tobramycin associated with less improvement than one drug alone, and using azithromycin associated with less improvement in response to IV tobramycin. That association or interaction was not seen with alternative antibiotics such as inhaled estrinam and IV clistamethate. But in a dedicated prospective trial, azithromycin use did not result in less benefit to lung function over a 6-week period, which actually trended in favor of the azithromycin arm rather than the placebo arm. And this was despite greater reduction in sputum Pseudomonas in the placebo arm. The very modest changes in lung function in the TEACH study in this kind of population, I think, support a need to better understand the clinical benefits of long-term inhaled antibiotic therapy in people with CF, particularly those experiencing better overall health. The idea of trying to prospectively study some of these long-term outcomes in a trial looking at this interaction is fairly daunting, considering the much lower rates of exacerbation and rate of decline in lung function. But the overall theme of trying to better understand what are people gaining from some of these long-term therapies that are identified by them as burdensome, I think is important to consider going forward. And I just want to note that the manuscript where we're able to discuss all this in much greater detail has been accepted for publication in Thorax. So those of you who are interested, I encourage you to find that and read that. So with that, I just want to thank many people who've been involved in these studies going back even to the early in vitro work, and specifically call out the TEACH study team. This took 5 to 6 years to finish, and we're very appreciative to the CF community, individuals with CF and their families, and also the sites who completed this study and stuck with us. The TDN Coordinating Center primary investigator was Nicole Meyer-Hamblett, and a number of co-investigators have been part of this for years, as mentioned. We want to really call out and thank our statisticians, as well as the whole TDN team, and the funding from the NIH and the CF Foundation, without whom this definitely would not have occurred. Thank you for listening today. I look forward to trying to address your questions here later.
Thank you very much for inviting me to speak today about the role for biologics in cystic fibrosis. I don't have any relationships to disclose related to this presentation. However, I did want to highlight that some of the recommendations are based on more clinical experience and extrapolation from the asthma literature. Now, over the next 20 minutes, I hope to cover a basic review of inflammation and how that relates to some of the biologic therapy. And then provide practical information about when to consider starting biologics in a CF patient, which biologics should we choose, when is the appropriate time to consider stopping or switching biologic therapy, so that you can bring back this information, this practical information, to your own patients within your clinics. Now, airway inflammation is a hallmark of CF. And we know that this occurs at a very early age and may actually occur even in the absence of infection. More recently, there's been evidence to suggest that CFTR modulators will reduce inflammation within the airways, but may not fully break the cycle of airway inflammation. We all have patients, though, that we can think about who have CF, but over and above their CF symptoms, they experience asthmatic symptoms that are quite difficult to treat at times. And this may be a person with allergic bronchopulmonary aspergillosis, or somebody who just experiences asthmatic symptoms with chest tightness, wheezing, and allergic type symptoms. Now, the cycle of inflammation, of course, starts with an abnormal CFTR protein. And this results in a dehydration of the periciliary airway liquid, which results in thick mucus, sets up a situation that infection can take hold, and our bodies send out inflammatory cells to deal with this infection, but unfortunately cannot eradicate it. And this results in tissue damage and ultimately end-stage lung disease. Now, in CF, we know that there is a higher level of inflammatory cells in the airways compared to people without CF. But even in individuals who have this asthmatic phenotype or allergic bronchopulmonary aspergillosis, they have an even higher level of inflammation within the airways. And this can be experienced as exacerbations of asthma or ABPA, a cyclical exacerbations that need further treatment. And this can be very challenging and often is not controlled with regular CF medications, but need additional things like steroids and antifungal treatments at times. Now, in reviewing this talk and preparing for this talk, I thought I would review the inflammatory cascade, which is quite complicated, as you can see on this slide. It was a little bit overwhelming, but I thought I would distill it down into something that's a bit more easy to digest. And this graphic shows that basically when our bodies are exposed to an allergen, it is brought into the cell and our inflammatory cells are activated. And a key cell that we need to consider is the Th2 or the helper cell. This cell secretes cytokines that stimulate various inflammatory pathways. For example, IL-5 will stimulate the production of eosinophils and increase those levels. Other cytokines will stimulate the production of B cells and differentiation into plasma cells and release IgE, which is another inflammatory biomarker. Now, the biologic therapies are available to us, and I'm going to go over what they are and when to use them. I want to start, though, with a clinical case, and this is a patient of ours, a 29-year-old male who has CF, homozygous delta F508. He's pancreatic insufficient and has CF-related diabetes, along with chronic infection with Pseudomonas. His baseline lung function is in the 50 to 60% range, but his history has been one of recurrent exacerbations and ABPA flares. And this has been problematic because he's required long-term steroids off and on throughout his life, and these have caused considerable side effects. And in 2010, he had a particularly bad course. And this started in early 2010 when he was unwell with a drop in his lung function, and he wasn't really responding to antibiotic therapy. So we again added in prednisone as well as itraconazole. And after several months, he was able to wean off the prednisone, his lung function improved, and his clinical state stabilized. And in October of that year, he was completely off the prednisone. Unfortunately, within a month, he actually became very unwell with a drop in his lung function to the lowest that it had been, down to 28% predicted. He was hypoxic and admitted to the hospital for IV antibiotics. And at that time, his IgE level was above 1,000. So we decided, okay, we're going to add in some IV Solumedrol. We put him on high dose steroids. And over the next little while, he started to clinically improve. He was discharged from hospital off oxygen. His lung function started to increase. And we also evaluated him for the possible use of biologics. Later in January, he received his first injection of Omalizumab. And I'm happy to report that by September of that year, he was completely off prednisone and his lung function was back to his baseline. And since then, he really hasn't had any further flares of his ABPA. Now, obviously, this is a very positive experience with Omalizumab, but I wanted to use it just to illustrate the potential benefit of this drug in this scenario. So biologics target certain biomarkers or cytokines, and these red arrows show the different ones that are targeted by the various biologics. Here we have the list of the 5 biologics that are available and approved by the FDA. And you can see that Omalizumab is the only one that really targets IgE. The other ones are focused more on IL-4 and IL-5, either the IL-5 cytokine or the receptor to which it binds. Dupilumab is the only IV injection biologic. The other 4 listed on the slide are subcutaneous injections, and these are readily available and easier to administer, obviously, than IV medications. Now, who should receive biologics? Now, again, we're using partly information from the asthma literature here, but these are indicated in uncontrolled severe type 2 asthma. So type 2 asthma is characterized by stimulation of the Th2 cells that cause increased eosinophilia and an elevated or increase in your IgE. And typically, this is characterized in the setting of allergic or eosinophilic asthma. So that's what's listed on the indications for these drugs. And additional indications were added later on, and they are listed on this slide, but notably absent is cystic fibrosis. So when we use biologics in CF, we're actually using them off-label. So when should we consider adding a biologic? Basically, in our patients who have uncontrolled asthmatic symptoms and multiple exacerbations despite maximal inhaled therapy, we might consider adding a biologic in those individuals who have also eosinophilic or allergic biomarkers, characterized by high eosinophils in the blood or in the sputum, high IgE levels, or perhaps a positive skin prick test to allergens suggesting an asthmatic or allergic component. And if people are on high-dose steroids and can't wean off the steroids and have multiple complications, these are also patients that you might consider. Again, this is looking at the Global Initiative for Asthma Guidelines. This is what's recommended in asthma, and we can apply this, extrapolate this to our CF patients. Now, what's the evidence that they are effective? On the left-hand side of the screen, you can see that in individuals with asthma who do not have CF, there's been multiple clinical trials with these medications to show a benefit in terms of reducing the risk of asthma exacerbations, decreasing the need for steroids, and also improving lung function. Unfortunately, we don't have that level of evidence in CF. And really, this has only been studied or published with Omalizumab and Mepolizumab in CF specifically. There's only one randomized controlled trial using Omalizumab, and unfortunately that trial was discontinued or terminated early because of poor enrollment and also increased loss to follow-up. So we're basing our evidence is based on basically retrospective studies only, so definitely not the highest level of evidence, but this is what we have to work with. So let's look at that evidence in CF. Specifically looking at Omalizumab, this drug has been the one that has been studied the most, and there are 19 publications looking at the use of Omalizumab specifically in ABPA patients with CF. This includes a total of 102 patients, and these are retrospective case series both in pediatrics and adults. And typically, these were started in people who did not have well-controlled asthmatic symptoms with standard therapy. And most of these studies showed improvements in symptoms and also reduction in steroids and sometimes being able to get off steroids completely, as well as stabilization of lung function. When we looked at the literature to see about asthma, there was really only one publication that was in cystic fibrosis, and these were patients who had a diagnosis of asthma without ABPA, and there was a total of 16 patients. And this also reported a reduction in steroid use as well as an increase in lung function. Now, in terms of Mepolizumab, there are only 2 publications that have looked at this in the setting of ABPA or in ABPA with an asthma overlap syndrome. And this is comprised only 4 patients. So based on this evidence, it does seem that Mepolizumab was well tolerated and helped to induce clinical stability and a reduction in oral corticosteroids. Although again, keep in mind, this is based on only 2 publications with 4 patients. In terms of benralizumab or dupilumab, we really don't have any evidence in CF specifically that these drugs would be beneficial. Which brings me to the next slide, which highlights a study that is ongoing with our adult clinic, as well as the Vancouver Clinic adult clinic in British Columbia. And we started this study to evaluate the effectiveness and safety of type 2 biologic therapy for asthma and ABPA in the adult CF population. And so far, we have 40 patients that are included in this study, 29 on mepolizumab and 11 on benralizumab. And we're looking at the change in lung function, as well as the change in cumulative steroid dose before and after the drug, and number of pulmonary exacerbations. I was hoping to have some of this data available, preliminary data available to share with you today, but unfortunately, we have not been able to complete this analysis in the time required. So we hope to have this information available in the coming months. So we'll hopefully be able to share some light or shed some light on whether these drugs have been beneficial in our adult CF population. So in summary, in terms of answering the question, do biologics work in CF? Most of the literature is with omalizumab, but it does suggest that there are improvement in symptoms, steroid-sparing effects, as well as reduction in exacerbations and an increase in lung function that's possible. But this is based on retrospective case studies, but it would seem reasonable that this drug be tried in certain circumstances. Now, which drug should we use as first-line therapy? There's really no right or wrong answer to this, and it seems that actually you could make a case for using either one of these in a variety of circumstances, but there may be some markers that will sort of tend to move you towards one versus the other. So if there's evidence of allergic asthma, as defined by sensitization on skin prick testing or elevation in IgE levels, one might consider using omalizumab as first-line therapy. If, however, there's evidence of eosinophilic asthma or in terms of sputum eosinophilia or elevations in serum eosinophil count, one might consider starting first the anti-IL-5 medications. However, there may be other things to consider, such as local payer eligibility criteria, because sometimes these drugs are covered by insurance companies and they have further additional requirements for coverage. So all of these things need to be taken into consideration. Now, once you've started a drug, you need to evaluate whether it's effective or not. The GINA guidelines suggest that these drugs should be tried for at least 4 months in order to assess effectiveness. And in our clinic, we often say up to 6 months. And one of the key factors that one would look at to assess effectiveness would be the impact on oral corticosteroid therapy, whether or not you can reduce the drug or get them off the steroid therapy completely. Of course, that's not the only thing to look at. One needs to consider symptoms as well as exacerbations when evaluating whether the drug is effective. Biomarkers have not been proven to be very helpful in predicting whether or not something is successful, but the other factors are much more important. Now, if you've started a drug and you are considering switching it, when should you consider switching? So, of course, if the person has had no response to therapy in the time limit that you've decided, 4 months, 6 months, that would be one reason to consider switching. Pregnancy is another one. Omalizumab is the only biologic that's been shown to not have teratogenic effects. Dosing is another thing to consider because sometimes omalizumab dose is quite high and requires multiple injections, and these can be quite painful and cumbersome. So it might be useful to consider switching to a different biologic in that scenario. Patient preference and side effects are also, of course, considered when switching medications or the need to switch medications. Now, some people have severe asthmatic disease and do not respond completely to one biologic. And it may be that there's a situation where you would consider adding in a second biologic that targets a different pathway. For example, using omalizumab as well as benralizumab in the same patient. This is particularly useful perhaps in overlap syndromes where you have eosinophilic and allergic asthmatic phenotypes. But there is minimal data on safety, and there's really minimal data on use in asthma and no data on use in CF. And this is important because obviously you need to balance the safety versus risks of using these medications. And if you're adding in a second biologic, there is a risk of impairing immunity and the risk of infection. And in CF, this is unique in the sense that these people have chronic underlying lung infections, and we need to consider whether or not that would worsen their infection. In asthma, they may not have that situation. So that is something that you need to consider specifically in CF. And you need to balance the risks and benefits. Having said that, we do have some patients in our clinic who have responded well to being on 2 biologics at the same time and have not experienced significant side effects. So in summary, biologics seem to have a role in CF based on the literature, both in CF and mainly in asthma, in the setting of uncontrolled asthmatic phenotypes. If you have a setting of allergic asthma, you might consider starting anti-IgE therapy first. If there's eosinophilic inflammation, then you might consider some of the other biologics that are targeting IL-4 and IL-5 first. I would recommend that you start therapy and evaluate at 4 to 6 months and consider stopping, switching, or maybe even adding a second biologic in some cases, but these need to be considered on an individual basis. Further research is really needed to guide recommendations. A lot of the evidence is based on the asthma literature, and we need to look at the CF population specifically in order to guide our recommendations in future, and new and updated research is badly needed. And that summarizes my talk. I'd be happy to answer any questions if you have, and thank you very much for listening and for your attention.
Hi, everybody. Thank you so much for the opportunity to speak to you today. I will be talking about antimicrobial stewardship in CF, and specifically focusing on the role of oropharyngeal cultures, as well as antimicrobial susceptibility testing. I have no relationships to disclose related to this presentation. For the objectives of this presentation, first we will define the goals of antimicrobial stewardship. We will also review the performance of oropharyngeal swab cultures, and then discuss the role of antimicrobial susceptibility testing in CF. So looking at the definition of antimicrobial susceptibility, the Infectious Diseases Society of America, along with the Society of Healthcare Epidemiology of America in 2012, have come up with a consensus, and how they describe stewardship was the coordinated interventions designed to improve and measure appropriate use of antimicrobial agents. And that's by promoting the selection of optimal antimicrobial drug regimens, including dosing, duration of therapy, and route of administration. And why is stewardship important is really that definition considered, when we look at the balance of what antimicrobial use represents, you have in the benefits the effective anti-infective therapy, which will allow for improved clinical outcomes, such as improving lung function, as well as nutritional status, eradication Pseudomonas, Orogenosa, and prolonging the intervals in between pulmonary exacerbations. In CF, increased survival related to antibiotic use has been an important component of the reason why it's used as a gold standard in that disease. In the counterbalance, you have antimicrobial resistance, which is emerging and becoming really a worldwide problem. And you also have drug-related toxicities, as well as secondary infections because of selections of pathogens by antimicrobial use, as well as gut dysbiosis. And then, of course, healthcare costs, which come into play with any antibiotic use. So the main principles of antimicrobial stewardship are really based on these key factors that Jonathan Kogan described. And then really we're going to focus today on 2 of these components, including the timely and accurate diagnosis of infection by identifying the target organism, as well as use of antimicrobial susceptibility testing in order to guide appropriate antimicrobial treatment. So to start with diagnosis of lung infection in CF. So of course, I over-summarize this, the main types of respiratory specimens that are used by clinicians for culture-dependent methods are oropharyngeal swabs, induced sputum, as well as bronchoalveolar lavage. So really the question of the presentation today is, will oropharyngeal swab cultures become more widely used in patients on highly effective modulator therapy because they will be producing less sputum? So really, this is maybe a lesson from pediatrics, which is my field, but when we talk about oropharyngeal swab cultures, this is really what is used for bacterial surveillance purposes in infants and young children with CF because they cannot cough on demand, they cannot expectorate, you cannot do induced sputum in them until they are a certain age and are able to do these things. The other advantage of oropharyngeal swabs is really the fact that it is less invasive than going for bronchoscopy to obtain a BAL sample. But the question is also, how well does oropharyngeal culture correlate with lower airway culture? So when we look at this, we start with data that spans over 20 years, really. So this is a review that was published in 2005, looking at the different studies in the 90s and early 2000s about this question exactly. And it was specifically looking at detection of Pseudomonas orogenosa because that is a pathogen that in young children and in young adults will lead to a significant intervention of eradication. So in these studies, as you can see, there were different age ranges, and the standard was consistently BAL. And then really the key component here is that the younger infants who were often asymptomatic, oropharyngeal swab cultures really had a lower positive predictive value, meaning that really it was not useful when we were trying to find if there was a good correlation between a pathogen in the upper and lower airway. On the other hand, negative predictive value was not as bad, as you can see in this table. And then in older children and young adults, including one of the studies by Ramsey, there was a little bit of a better positive predictive value, and that's probably because the prevalence of Pseudomonas increased in that age range. And then more recently, in 2018, there was this study including 181 young children with a median age of 3 years, so really the younger kids. And they had quite a lot of samples, so more than 600 paired oropharyngeal swabs and BAL cultures. As you can see, the sensitivity of oropharyngeal swab culture was really low. And really interestingly, a positive culture for Pseudomonas orogenosa was really poorly concordant with a positive BAL culture. So in this receiver operating characteristic curve on the right, you can see that the area under the curve was actually quite low at 0.5. There was also secondarily no significant associations with marker of lower airway inflammation. They had looked at neutrophil elastase as well as IL-8, and then no association with progression of structural disease, pulmonary exacerbations, and also lower airway Pseudomonas aeruginosa positive cultures in the subsequent year. When we look at more culture-independent methods, right, that are becoming an emerging diagnostic tool to look at lung infection in CF, you could see this study from 2015, which really was one of the first studies to use sequencing in order to compare those two types of respiratory specimens. So in 16 expectorating children, and that's important, right, because in the pediatric population, as we mentioned, not all children expectorate. In these expectorating children, there were samples that were compared, including oropharyngeal swab cultures versus expectorated or induced sputa, as well as saliva. And then really what it showed is that for both Pseudomonas and Staphylococcus, they were detected in higher relative abundance from the lower airway, so from the expectorated sputum and from the induced sputum, compared with the paired upper airway samples, including oropharyngeal culture. So that's important to know, right? So basically the conclusion of this study was that using culture-independent methods, oropharyngeal swabs are really not the recommended specimen to use. And then fresh off the press in September of 2021, we have this study, which is the first study looking at similarly that comparison, but in adults. So they had 22 adults as well as 8 children, 75 respiratory cough swabs and sputum samples. And using sequencing, they showed as well that for the main pathogens of CF that are listed in color here, you could see that culture-independent analysis of the cough swabs were not really able to discriminate between a positive or a negative result when compared to sputum culture. And that was using dependent or independent methods. So their conclusion was also, what is the role of oropharyngeal swabs or cough swabs, because they were using adults so they could, indicate for them to cough. Really, it performed less well than using sputum sample for this culture-independent method, at least. So really, with that data that spans over the last 20 years, what that tells us is that the reality for us in pediatrics is we have to use oropharyngeal swabs because the children are not able to give us sputum, and we don't want to submit them to invasive procedures in order to get a BAL. But it doesn't necessarily have the yield that allows us to feel always comfortable knowing that we have discovered the right pathogens that are in their lower airway. And then I think a really important point, and I know there's a commentary, I don't have much time to present it to you, but there is really the question that there's nothing evaluating other types of microorganisms such as non-tuberculous mycobacteria using those specific respiratory specimens. So it's important to keep in mind, because I think as adults, older children as well will be on highly effective modulator therapy and may expectorate less or even produce less sputum. It will be interesting to see even if induced sputum is as effective as it currently is. And then maybe clinical practice will be, there will be some temptation to use oropharyngeal swab cultures, but it is questionable whether on its own, without any kind of other further method, it may really indicate a proper microbiological diagnosis. So now on to the second topic. So when we talk about antimicrobial susceptibility testing, so I think really what's important, and that's a nice review in clinical infectious diseases, I think that what's important to say about susceptibility testing is that the goal is really to ensure that you're picking the right antibiotic, so the right antimicrobial regimen. And really also an important point is to monitor if you have resistance, right? That this is how we find out that there is antimicrobial resistance on the rise. So an important fact, however, is that it is really used and most predictive in settings where you have a planktonic or a free-floating, microorganism that is really, there's just one. It's a monomicrobial type of acute infections. The classic example is the bacteremia, where you really have this one bug, and that is in the free-floating form. And so your antimicrobial susceptibility testing will really be indicative of what's circulating in that organ space. And then the other fact is also the fact that when we use antibiotics and antimicrobial susceptibility testing for this is usually in settings where antibiotics are used really to kill the bacteria. And that might be a little bit different from CF in the sense that in CF often we might try to suppress or diminish the quantity of bacteria depending on the clinical situation, of course, but for the most part, it's not the same thing as trying to completely sterilize a compartment of your body. And then other important CF-specific considerations are the fact that unlike these infections that I just described, when we talk about the respiratory tract of CF, it's really a diverse polymicrobial community kind of setting. And these communities interact with each other, and that in itself might influence how they will respond to antimicrobial therapy, and how susceptible they will hence be, right? And then the other thing is, whatever you find, does that really mean that this is what is causing the clinical deterioration or the clinical symptoms of your patient? So that causality is not as clear necessarily as when you may find a bacteria in a CSF. And then there are specific conditions or environments in which the bacteria and the other microorganisms in CF airway act, and that's the fact that they adapt, right? So the more time goes on, the more they will adapt and develop these mechanisms, which may influence how they respond to antibiotic therapy. So that includes, for example, in the example of Pseudomonas, biofilm formation, but even in the different clones and within clones, genotypic and phenotypic diversity. So they will not always all respond in the same way, and we might see even phenomenon of heteroresistance, for example, where within one community you will have a subpopulation that will not be as susceptible. And then finally, the CF lung really is a hypoxic and acidic environment, and the effects in their own of antibiotics there may be different than what we would expect when we do in vitro antimicrobial susceptibility testing. So in order to synthesize all this data, Dr. Somayaji did a beautiful systematic review recently, which really looked at the predictability of clinical response in pulmonary exacerbations to antimicrobial treatment, really based on antimicrobial susceptibility testing. And what you could see from all these studies that are listed is that for the majority, most studies really are not in favor of using antimicrobial susceptibility testing to predict clinical response to pulmonary exacerbation. So really over the course of the past few years, the scientific evidence that's been published really does not show us consistently that it is a useful tool in order to choose antimicrobial regimens. And speaking about stewardship on the counterbalance, when people who maybe are not so used to practicing with CF patients might apply the same paradigms, the same methods as for other patient populations, and therefore may broaden, for example, spectrums of antibiotics that don't always correlate with a better clinical response. And that's important because that is something that needs to be circulated as a message for example, infectious diseases specialists that are not specialized in CF care. So you see there were two studies that really showed that there could be a predictable clinical response from AST results. So let's look at these studies more in details. So one of them was from 2009, and it was a multi-center randomized crossover study comparing the safety and efficacy of continuous infusion with those of short or intermittent infusions of ceftazidime. And then really what you could see from this graph on the right is that there was reduced lung function recovery in subjects that had resistant Pseudomonas aeruginosa isolate when they were treated with intermittent ceftazidime infusion. So that is one study that really said, yes, maybe there is a little bit of a discrepancy. Maybe when it is resistant, the patients may not respond as well. But it's questionable how it was not always reproduced from other studies. In the second study, we have a retrospective design, and it included over 400 pulmonary exacerbation treatment failures. And then what they found is that really there was a significant inverse correlation between failure rate and number of antimicrobials to which isolates were susceptible. However, when the model was, when the analyses were looked at with a multivariate logistic regression model, really adjusting for other factors such as the severity of pulmonary exacerbation with the lung function drop and the inflammatory markers, while anti-susceptibility testing results were no longer a significant factor. So therefore, the conclusion is there may be some impact, but really overall, probably not. And then in a recent study from last spring, this was looked at in a large study, which was retrospective with over 3,000 pulmonary exacerbations, 400 patients. And what's interesting is, the pulmonary exacerbations were looked at for Pseudomonas coverage in terms of whether the Pseudomonas coverage was complete, meaning all isolates were susceptible to at least one administered agent, or not at all susceptible, incomplete, which means some of the isolates were susceptible, or there were some drugs that could cover pseudo, but we did not use antimicrobial susceptibility testing. So as you could see from the graphs, and then hopefully you'll have time to look at the PowerPoint more calmly than just in this quick look, really there was no association found between the Pseudomonas aeruginosa coverage based on antimicrobial susceptibility testing and the clinical outcomes, including lung function change from baseline to follow-up, weight change, as well as the time to the next pulmonary exacerbation. So more data, more recent data showing us that probably antimicrobial susceptibility testing does not well predict whether the patient will get better on the regimen that you've picked. The other question is really the methods of antimicrobial susceptibility testing that are used. So when we look at combination testing, there was, as you probably know, a large randomized double-blind controlled trial in 2005 that was published in The Lancet, where over 250 patients were enrolled and 132 were randomized. They were chronically infected with multi-resistant gram-negative bacteria. And really what was looked at was whether multiple combination antibacterial treatment was when you use that combination antimicrobial susceptibility testing to pick your regimens, was there a better response in terms of time to the next pulmonary exacerbation? And as you can see from this Kaplan-Meier graph on the right, that was not the case. So not indicative of remaining exacerbation free. So there was also secondarily no difference between the groups in terms of mean lung function recovery, respiratory symptoms, and sputum bacterial density after 14 days of treatment. So that method did not change much. And then when we also look at whether biofilm versus planktonic, as I had mentioned earlier, in terms of how the bacteria adapt in the CF airway versus how we tested in vitro, there was a multi-center double-blind RCT of 14 days of IV antibiotics, which were chosen based on either conventional or planktonic antimicrobial susceptibility testing versus biofilm, and that in almost 40 CF patients with 74 pulmonary exacerbations who had chronic Pseudomonas aeruginosa infection, really showed that both in terms of, in this study, the primary outcome was actually sputum Pseudomonas density. You could see that did not really change anything. And then in terms of the secondary outcome, which was lung function improvement, it was also similar between the two groups. So the groups randomized to conventional and the group of biofilm susceptibility testing. So the method of susceptibility testing also does not necessarily help us predict better in a more granular way whether the patient will be responding or not. And I think this is a really nice graph also from that systematic review. I think what's interesting about this is really what clinicians have to face, in the antimicrobial choices that they make for their patients with CF lung infections all along their lives. So really, it's the relationship between, the patient's clinical factors such as their age, how severe their CF disease is, how many antibiotics they've gotten, and not only how many, but how long, right? And cumulatively, how much they've gotten. And then how that may have impacted their airway community diversity, as we know that, the later in CF life we go, the more there is a certain predominance of certain strains and certain clones. So really, I think that that's an important graph because it shows us it's not just we can't just look at the literature and say, well, antimicrobial susceptibility testing is good for nothing. I think there is a lot of evidence showing us at least that we shouldn't base all our decisions of what antimicrobials to choose solely based on this, on the opposite of other infections where sometimes we do, right? But I think in CF, there are all these particularities that are very much patient-centered, very much patient-specific, a little bit case by case, where sometimes we will consider a little bit of the resistances that we see when we've failed to achieve a good clinical response and we have to pick broader antibiotics, which may have more side effects. But certainly, I think the key message that I want to circulate is that for the most part, you may be able to just use the antibiotics that your patients respond well to and that they tolerate the best. So in terms of the conclusions of this talk, I think, first of all, we're in an era where certainly antimicrobial stewardship is very relevant. It will take a lot more space in future years to come. And it is very important in CF care. I think there is a role for it where we precisely may be able to, with some decisions, avoid choosing antibiotics without a good thought process behind it. And then certainly the yield of oropharyngeal swab using both culture-dependent and culture-independent methods has been proven to be limited so far. So I think the question will be, well, we need more research, right, to know what we will use either with that, in association with those respiratory specimens, or completely other methods in order to improve lung infection diagnosis. Because as our patients thankfully will be on modulator therapy, we will need a way to really diagnose them and monitor them and see how they respond to antimicrobial therapy as well. And then finally, I think that, as mentioned, clinicians should really prioritize patients' clinical responses, and I didn't mention it here, but tolerance to antibiotics in terms of side effects, over in vitro antimicrobial susceptibility testing results, really to choose their antimicrobial regimens for CF. So thank you very much for listening, and I hope that you enjoy the rest of the symposium.
Hi, my name is Jason Woods, and I direct the Center for Pulmonary Imaging Research at Cincinnati Children's Hospital and the University of Cincinnati. And I'm going to talk to you today about imaging for longitudinal changes and treatment response in adolescent CF lung disease. I do have a couple of disclosures. First, I have investigator-initiated research support and consulting with Vertex Pharmaceuticals. And then a fair amount of our MRI work is performed under an FDA IND for Xenon. So this talk is really about structure and function, and I've split it into two parts. So with function, we usually get that via hyperpolarized gases. Here I'm showing you Xenon MRI, hyperpolarized Xenon. And I'm going to spend the last half of the talk talking about function, and the first half actually talking about structure. So typically we see structure via CT or UTE MRI, that's ultra short echo time MRI. CT is the clinical gold standard though, and so this is a typical CT in a CF adolescent where you can see very clear bronchiectasis, central and peripheral mucus plugs, and peribronchial thickening. By comparison, this is a UTE MRI of a patient that we just imaged the other day. So I'm showing you very routine images, not our best images in the world, but you can certainly pick out bronchiectasis, central and peripheral mucus plugs, and ground glass opacities that are very typical of CF lung disease. So typically what a person would do would be to identify and maybe even segment out the bronchiectasis, the central and peripheral plugs, the consolidations, the peribronchial thickening, and the ground glass. And so what we wanted to do was to remove the person from that a little bit and try to do an artificial intelligence algorithm because there's been a lot of work that has ultimately shown that reader scores are a little bit less perfect than algorithms that the computer can generate. So what we did was to do an artificial intelligence study, and we wanted to use deep learning or convolutional neural networks for training the computer to see these abnormalities. And so this is exactly what a manual segmentation would look like. You'd have to go in and manually segment all these green areas for peribronchial thickening, separate from the red areas for bronchiectasis, in order to get a quantitative number out. And so that's ultimately cost prohibitive. So in manual segmentation, we would need at least 150 patients for any artificial intelligence method to begin to remotely work. And when I've done this before, when I was really efficient, it took me about 1 day per patient for 250 to 300 CT slices per patient. So when you add that up, if I wanted to have a board certified radiologist do these segmentations, that would be somewhere between 150 and 300 actual days, full days of work, which would be a very expensive study, and it might make a person go insane. And so the solution here was that Dr. Dorn from Bordeaux actually came to our lab for a sabbatical, and this is part of his project, was segmenting these lungs and implementing the AI algorithm. So the data and study were from 3 sites, that was Cincinnati, Bordeaux, and Pessac. From 3 CT vendors, so that adds a little bit of robustness to the study. We had a total of 184 patients, split between adult and pediatrics, 78 training, 36 initial validation, and 70 clinical validation. And the big bonus here, and the reason why I'm presenting this here, is that 70 of these patients had follow-up CT. 10 were after lumacaftor, ivacaftor treatment, and 60 were after routine follow-up. So we manually segmented 254 CT exams, and that's approximately 70,000 slices that were manually segmented. So this is actually a fair amount of work, let's say. We trained 4 convolutional neural networks with data augmentation, and the idea was that we wanted to use a majority vote between those 4 models, and that was the ultimate and final AI segmentation. So this is an example of a 15-year-old female and a manual segmentation. This is one slice where I'm showing you the peribronchial thickening, the bronchiectasis, and mucus plugs, and it's perhaps better appreciated with the 3D rendering here, showing you by color those different pathologies. And then this is the AI segmentation. So in this individual slice, you can see that the AI segmentation is nearly identical to the manual segmentation, but we miss a few things. And this is a little bit on purpose. So I really didn't want any false positives. So for example, that little chunk right there, which the radiologist called a mucus plug, I did not want for that to be called a mucus plug when it was actually a vessel. And so we were a little bit conservative on the mucus plugs because I wanted to make sure that all of the normal lung was actually normal. So here I want to show you an animated video of axial slices of one patient going axially from the top down, and then an AI algorithm. There we go, finally. Here you can see bronchiectasis. I'll stop in the middle. You can see bronchiectasis, a little bit of consolidation, and some mucus plugs. And here is the AI algorithm. I'll stop there. You can see bronchiectasis, peribronchial thickening, consolidation, and plugs. And this is much more easily appreciated, I think, in the 3D surface rendering here, where you can see that the majority here of abnormalities are mucus plugs and peribronchial thickening with a big area of consolidation. So here are 3 patients that increase in severity from an FEV1 of 100%, 82%, and down to 55%. And you look at these individual slices and you can see abnormalities increasing. The bronchiectasis is present here, and it's much more difficult to see here. In the 32-year-old female, the bronchiectasis is bigger, peribronchial thickening is bigger. But the 3D rendering really gives you an impression of the differences between these lungs. In the milder disease at 82% here, you see a preponderance of thickening and mucus plugs. And in this patient, you see preponderance of thickening and bronchiectasis. And I'm trying to imply that this is ultimately more correctable than this in terms of treatment. So the bonus and the more exciting part here is the treatment response. So this is a patient pre-lumacaftor, ivacaftor, and a patient post-lumacaftor, ivacaftor. And you can see the AI algorithm here, and you see a few differences in these slices. But when I do a 3D rendering, you can appreciate that, oh, the total volume here subtended by the junk is 65 cubic millimeters, and here it's 19. So all of these mucus plugs simply melted away after treatment, and that's very easily appreciated via the algorithm and in a 3D rendering. So the results were pretty good here. The whole lung concordance between the AI-driven calculations and those of the ground truth, that was the reader segmentation, were very good to almost perfect. Recognition of normal lung showed almost perfect levels of pixel-wise similarity. That's where we're comparing pixel to pixel variations. And importantly, the AI-determined pathologies significantly correlated to PFT and to visual CT assessments. We did it via the Birdie score, but the same would be true of the other scores like Pragma or the Wilkes-Barre score, both an initial eval and follow-up. And then this is the really good stuff, and that is that CF with this treatment, and only 10 patients showed a statistically significant improvement at 1 year, notably with peribronchial thickening and mucus plugs, but not with bronchiectasis. And that would fit most people's hypothesis that the mucus plugs and some of the thickening are correctable, and the bronchiectasis is not. And CF without treatment, that was 60 patients, had an increase in bronchiectasis and peribronchial thickening volumes at 2 years of routine follow-up. So this just came out in the European Respiratory Journal, so I hope you'll have a look. But that was the first time that imaging actually has shown this kind of a difference. So next to function, and that's with hyperpolarized xenon. So here I'm showing you ventilation. So we prepare this magic bag of hyperpolarized xenon with a laser polarizing apparatus. Ask the patient to simply inhale the gas. So the patient needs to be able to comply enough. And for us, that's routinely in patients 5 and older. And then simply acquire slices over a breath hold of 10 to 15 seconds. So a very simple kind of imaging technique. And you see the gas goes where the gas goes during this approximately tidal breath, slightly larger than a tidal volume. And those areas that are bright represent where the xenon goes, and those areas that are dark represent where the xenon does not go. We can ask a computer or a reader to identify those defects, which I have here in red. And it turns out that in all of our control patients, we have very, very uniform ventilation. So here's a patient, 6-year-old female, 95% FEV1, but basically no ventilation defects. And you can see qualitatively that the ventilation is really uniform. We compare that to a 15-year-old female here with a 72% FEV1 and a ventilation defect percent of 32%, and the defects here are pretty stark. But importantly, even in those patients that have a high FEV1 and have cystic fibrosis, we see ventilation defects. And so that were 2 more extreme examples: a sicker, slightly sicker patient, a patient that has absolutely normal lung function. And this is something a little bit more typical, where we have an FEV1 of 85%. This is a patient just a few days ago, a 9-year-old male, and you see very clear ventilation defects throughout, in this case, the right lung. So hyperpolarized xenon MRI can depict and quantify regional ventilation. Here I'm showing you just examples in a cadre of patients, healthy, BPD, asthma, and CF. We can measure alveolar size via the apparent diffusion coefficient. This has been a well-validated technique. And here, just to show you, healthy, here's a 20-year-old BPD patient, a COPD patient, just to show you the range over which we can calculate alveolar airspace size. A little bit relevant to less relevant to CF, but may become more relevant as the lifespan increases. And we can also measure xenon that is dissolved into the interstitium and the red blood cells. So this is what we call gas exchange MRI. It's the newest version of xenon MRI, but it allows us to quantify xenon and interstitial diffusion-based abnormalities and perfusion-based abnormalities. Because that's newer and I don't have as many results in adolescent CF, I'm not going to talk about that. But xenon ventilation is particularly sensitive to early obstruction. So we calculate this via the ventilation defect percentage, as I mentioned on the previous slide. Here's 1 control patient and 2 CF patients with their FEV1s listed. And when I compare CF patients with preserved lung function to controls, and by preserved lung function, I mean I'm selecting those patients that have an FEV1 of 80% or greater. I had 36 of those patients and 10 control patients. And I look at group separation. In other words, can I statistically separate the group CF versus control via FEV1 compared to imaging? When I do it via FEV1, my p-value is about 1. And when I do it via imaging, my p-value is about 0. Okay, so that doesn't take a very fancy statistical test to convince you, hopefully, that this is a sensitive technique compared to FEV1. And it turns out that we and others have demonstrated this much more rigorously than I'm showing here. But it turns out that xenon ventilation MRI is more sensitive than FEV1 and more sensitive than LCI, particularly in early or mild obstruction. There was a published 2 study two-site study in adolescent CF. This was Cincinnati and Toronto, where we compared the ventilation defects in a similar group of patients at each site, and then analyzed data with analysts from each site, and showed very little variability between these two analyses. But importantly, we really needed after this a prospective multi-site study of variability. And that's where the CF Foundation helped us in terms of funding. So this is an ongoing 4-site study funded by the CF Foundation in Cincinnati, Toronto, Wisconsin, and the University of Virginia. It's called HighPoint, Hyperpolarized Imaging for New Treatments. And the first phase of this was simply variability in pediatric CF from 6 to 18 years old. And this is an example of what we did. We imaged patients at baseline, supine in the magnet. These are coronal slices in this instance. Had them get up, walk around, and then ultimately come back. So this is a span of 1.5 hours in between these two experiments. And you can see nearly identical images visually. When we ask a computer to identify these, of course, the images aren't always in exactly the same position. The computer said 5.5% versus 4.9%, so about 0.5% variability. The readers had almost identical reader defect volumes here at 0.9 and 0.8%. Another thing, we ultimately analyzed this variability now in 23 patients, and I'm showing you here a Bland-Altman plot of those 23 patients with a mean age of about 13 years, mean FEV1 of 95%. So the VDP repeatability had a mean difference of about 0.3%. So a very small amount of same-day variability, and so that's much smaller than FEV1, for example. And in terms of longitudinal changes, part of an ongoing R01-funded study was in pediatric CF 12 to 18 years old, and this is just to demonstrate longitudinal changes. Here I'm showing you a patient at day 0, no treatment changes, and this is an F508del heterozygous patient. And you see all kinds of ventilation defects around the periphery in particular, these dark spots. And then almost a year later, you see some changes. So what I want to do is highlight some of those changes just to demonstrate. So first, you're struck particularly by the changes that get worse. So these ventilation defects that appear at day 247 or appear at day 751 that were different, and they show a worsening or an increasing of obstruction. And then when you look a little more closely, you'll see some areas that actually improve. So these peripheral defects here have mostly gone away. That defect there mostly went away, etc. And then you look even more closely and you'll see plenty of defects that are simply stable over time. So scientifically, I hope you're thinking, well, what are the differences between these treatable and stable defects? So if these things improved or got worse, are they? Can we predict the treatment? Can we predict which ones are stable? Which ones are mucus plugs? Which ones are more bronchiectasis? And those are questions that are the subject of ongoing research. In terms of longitudinal changes as a result of treatment, here is one patient, F508del homozygous patient, and this is before and after initiation of lumacaftor, ivacaftor. And the ventilation defects here are a bit more subtle, okay? So this is after treatment, and you're starting to look at the images. So first of all, your eye probably goes to these areas that basically didn't change. So almost nothing changed between these areas that I'm highlighting here. But you look a little bit more closely, and these areas did change. So we have 3, maybe 4 defects here that got better after treatment, and they're very subtle. One defect got a little bit worse. So there's a small weirdness right there in the initial images, and that got worse after treatment. Here's a different patient, and this is day -1, 176, and 547, so treatment was right here. And this is a little bit more subtle also. So many of these areas actually got better. Okay, so I have poor imaging on the first day, sorry about that. But you can see that there are some improvements in the ventilation defects where I've circled them in green. You'll also note that between day 176 and 547, where the treatment was stable, the patient clearly got worse in terms of obstruction. Okay, so those subtle defects are there because the disease is progressive. And in summary, I'll simply say that AI algorithms quantify these changes and treatment response in structural imaging, that's via CT. UT MRI may be a good alternative for pediatrics. And that Xenon, hyperpolarized MRI, is very sensitive to obstruction. We have low same-day variability, about 0.5% or less. We're sensitive to disease progression, and we're sensitive to subtle changes as a result of treatment. Those subtle changes are important from my perspective. And so that means that there really is potential for much more personalized evaluation and treatment. And I'll stop there and say thank you.
Much for all of our speakers today, and thank you for those of you who've already started putting questions in Slido. So now we're going to invite all our speakers, and I'll be directing some questions, so keep them coming. I'm going to start with Dr. Stevenson. Can you comment on the use of biologics for CF sinusitis and those with allergies and uncontrolled sinus symptoms, specifically in this case the use of dupilumab?
Thanks for that question, Dr. Corriveau. And it's a great question, because that medication does seem to benefit people who have sinus disease and polyps. We don't know, as I mentioned in the talk, there's not a lot of literature in CF specifically. So it's hard to say, but the pathophysiology of nasal polyps in CF is really felt to be more due to neutrophil inflammation rather than eosinophilic inflammation. So I'm not sure that these medications would necessarily benefit people with CF. It's something to consider, but the literature, there's not a lot of literature to suggest using them in that setting quite yet.
Thank you. Next question I have is for Anna. Can you comment on the use of dual antibiotic therapy for Pseudomonas? ID folks often prefer single antibiotic use, and I've had the same experience. So I wonder if you can enlighten us on whether dual antibiotics are needed for Pseudomonas.
Thank you for this question. I believe so far that's what that remains a recommendation. I don't know if it will always be the case. I do know that being Peds ID, I can attest that I think, as I've mentioned, we do approach perhaps infections differently in CF. And so because of the risk of perhaps certain subpopulations, we do often try to recommend double coverage, although some ID folks do come in and then just use the one antibiotic. I can't say that I've reread the literature about dual coverage and whether it performs better and if the evidence is solid for that. So, I think it's something that has been extensively studied, but so far the recommendations were still double coverage the last time I checked.
Thank you, Anna. This question is for Dave. So from the studies done so far, in your experience, is there any reason to hold chronic azithromycin while patients are receiving tobramycin, specifically when they're receiving intravenous tobramycin?
Thanks, Sophie. So I think many of you know, those who may not, azithromycin is remarkably good at concentrating in the airway, and particularly in leukocytes in the airway, thousands of fold higher than serum. And you can measure azithromycin in those airway leukocytes, 2 to 4 weeks afterwards, even longer in some studies. So it's hard to conceive of a way where we could practically delay IV antibiotic therapy long enough to reliably wash out a macrolide before it were used, if we, felt confident that it was an issue. So I guess the point is, I would not recommend trying to do that necessarily. I think if people want to stop azithromycin while people while they're treating individuals with IV antibiotics, I think that's a personal choice. I don't know that the guidelines in recommending chronic therapies necessarily apply to macrolides, given people are on other antibiotics at the time. But I don't think it's very feasible to stop it with enough time in advance to avoid this potential drug interaction.
And just to follow up to that, because a lot of our patients are on inhaled tobramycin and chronic azithromycin, from pediatrics going into adulthood. Do you still have patients on both of them? Or again, are you avoiding them together based on the data?
Yeah, I saw that question as I was monitoring the slide. I'm not sure why my particular personal practice helps anyone else, but I'll be happy to answer the question. So I do have patients who are using both. I, like all of you, try to sit and decide with individual families and making those decisions. What's the best approach, and what are our goals to therapy? What do we know about the short and long-term effects? So as you know, I highly value data from prospective randomized trials like the one we did with TEACH. And so I weigh that evidence heavily. But even in that study, we saw evidence that killing Pseudomonas may be diminished. I would be more confident in the lack of any clinical impact if we had seen a positive clinical impact in that study, meaning an increase in FEV1, and we did not. So there is a remaining question about whether or not it may reduce some other clinical impact of inhaled tobramycin, and we just don't know. And so I can't tell you that it's a problem. Personally, I sometimes will avoid it if I have other suitable options, other inhaled antibiotic options, and the family is willing to use that drug, which may require 3 times a day dosing or other disadvantages. So.
Okay, thank you. So the next question I have is for Jason, and I'm very interested in this as well. So the research you've done with hyperpolarized gas MRI is very fascinating. When do you think we can expect to see this used more broadly in clinical care? And also, what are some key remaining questions or challenges with this?
That's a great question. And predicting the United States FDA is sometimes as difficult as predicting U.S. politics. So I think that I would predict that we would have clinical approval in adults of hyperpolarized xenon by sometime in the spring of 22. Now, with that said, I have to caveat that it's, again, difficult to predict the FDA. The remaining challenges, I think, have to do with pediatrics and with other indications. So the indication that's been applied for is simply ventilation, and that was the subject of my talk, was detecting early obstruction, and I think it'll be clinically useful when we have that label indication. But the gas exchange MRI will be particularly useful for understanding pulmonary vascular abnormalities. And so there are some additional challenges in clinical trials that have to happen to demonstrate that to the FDA.
Okay, thank you. I'm going to go full circle, if that's okay with you guys, to sort of go around. So next up is Dr. Stevenson. You mentioned that you guys are doing a study looking at your own experience with biologics between the Toronto and the Vancouver site. To date, are there any patient-reported outcomes that may speak to other relative advantage of taking these medications?
That's a great question. So far, the literature, as far as I'm aware, has not reported any patient-reported outcomes. They're mainly focused on lung function exacerbations and the need for oral corticosteroids. But this is a really important point because, as I mentioned in the talk, sometimes this therapy requires multiple injections. So for Xolair, for example, if the dose is too high, it has to be broken down into 2 separate injections, and the injections themselves can be quite uncomfortable. Patients have reported that just on their own to us at our clinic. So, I think that needs to be taken into consideration. As well, often, up until recently, actually, patients had to go to a clinic specifically to get these injections. And Xolair is more frequent than some of the others, being given either every 2 weeks or monthly. And then some of the other biologics are given monthly and even every 2 months. So it's maybe less of a burden to go to a clinic, but still to have to go somewhere to get that injection is something that needs to be considered.
I know that more recently there's been auto injectors that are available, so patients can actually do the subcutaneous injection themselves, which of course would make it a lot easier for patients not having to travel and go to a clinic specifically for their treatment. So that might help. But I think it's a good point in just thinking about our study. It is a retrospective study, so we're basically doing a chart review specifically looking at some of those outcomes that I mentioned. So it may not be possible to look at patient-reported outcomes per se, since if they're not recorded in the chart, we wouldn't have access to those. But moving forward, I think that's something that does need to be looked at and taken into consideration in future studies.
Okay, great. So next up, Anna. So if antibiotics selected by antimicrobial susceptibility testing isn't necessarily the best approach, how would you suggest selecting antibiotics, particularly when there's multiple respiratory organisms?
Yeah, I think that's a great question because that's the reality, right? That often we do have cultures that show polymicrobial infections. I do think that for the most part, in practice, what is done is, we try to look at which organism has been predominant, right, for the patient on a longer period of time, and most recently before the clinical deterioration. And then certainly whenever possible, at least as personally as a peds ID person, I try to do combinations that may cover at least 2 of the bugs when we find them, whenever it's possible. And then that's obviously done with respect to what the patient can tolerate, as well as to decrease as much the innocuity or the side effects that the patient may experience.
Great, thank you. So next question I have is for Jason. So Jason, I'm wondering if you can comment on whether or not we should be doing functional the CTs prior to starting modulator therapy, and if this is something that we should then be following.
Yeah, it's a bit of a trick question because I do think that imaging is a good modality for really understanding the changes in treatment. The algorithms that I showed here today, those artificial intelligence algorithms are not clinically available yet. But if one were able to do a CT before and after treatment and it had an effect upon the family, so if the patient and the family then understands and it becomes real that the treatment is effective, then I think it has a significant clinical benefit, and that benefit would outweigh the very, very small risk of a little bit of ionizing radiation. If you transferred and did MRI before and after, then you would at least get rid of the ionizing radiation, would probably be able to see those differences before and after. And we've run into the same problem with analysis, in the sense that we don't have routine techniques that are employed in the clinic to do that kind of 3D quantification. So my answer is yes, I think it's clinically beneficial. Some of that benefit has to do with the patient actually seeing the results and not just feeling it. Like usually there's a feeling change. And then moving forward, if we can allow some hyperpolarized gases, then those treatment changes should be stark.
And on a follow-up question to that, because we don't personally necessarily get CTs at baseline for patients. So would you recommend that patient get even a baseline CT when transitioning from pediatric to adult care, with or without modulator therapy?
I think that's I'm sort of on the fence on that one. There is clinical benefit to understanding changes over time and what those changes are. So if the primary reduction in FEV1 is a result of mucus plugging, that would be visible on CT. And if you could understand that clinically, then I think there's significant clinical benefit to getting that baseline CT. If the CT is perfectly clean and shows nothing and the FEV1 is 100%, then there's only a small clinical benefit, but at least it allows a baseline for future comparison. Because I suspect that as we go forward, we're going to get more and more personalized in the therapies and potentially even try to understand regional abnormalities in treatment.
Thank you. Anna, what would you say? what would you say the rule is, Anna, for induced sputum instead of using oropharyngeal culture or BAL?
Yeah, that's a good question. I couldn't go too much in detail in my talk about induced sputum, but certainly in the literature, there's good data showing that it is a good substitute, if I can use that word, instead of BL. So it does perform better than oropharyngeal cultures. I can say that at my center, certainly our CF clinic director has worked very hard to put in place a good protocol so that induced sputum could be done for kids followed at our center. And I think that certainly has more evidence that it correlates better with lower respiratory airway pathogens. So I think when we say what is the rule, if I think I read one of the questions that was written regarding clinical decisions such as stopping, for example, inhaled antibiotics, I do think that the yield of induced sputum may be higher than oropharyngeal cultures for those decisions.
And just to follow up on that, so what is even the role of surveillance oropharyngeal swabs? Because I noticed at one point in your talk, you said, we're still using that because that's what we have. But if your positive predictive value is low and your sensitivity is low, are you doing this in asymptomatic children, or is it predominantly when they have symptoms?
I think the issue is very much for us age related, because when they are babies or when they're young children, induced sputum is not necessarily an option. So certainly for the younger kids, oropharyngeal culture is what we have. And so that's what we use for routine surveillance purposes. So when they come for regular clinic visits, and certainly for their yearly workup, that's what is used. In older children, ideally when they're able to cooperate for induced sputum, then we try to get that kind of specimen.
Great, thank you. Dave, in the TEACH trial, given the change in sputum Pseudomonas density, do you think that a longer study would have proven your hypothesis regarding the FEV1?
Yeah, it's a good question. I don't know, but my guess is probably not. I think we observed that those who are on longstanding inhaled tobramycin really don't see a dynamic change in their FEV1 with use of inhaled tobramycin. That was regardless of azithromycin or not in the randomization scheme. So I doubt that if we had gone, say, 3 cycles, 6 months, we would have seen big changes in FEV1 that then we could then test whether or not azithromycin is reducing that. Were we able to do a study looking at risk of exacerbation? Perhaps we could ask those kinds of questions. But then you run into this balance where azithromycin itself seems to have a protective effect against exacerbation. And so that may negate the effect seen. So I doubt that we would see a difference if we did do a longer study. And it's worth maybe pointing out here, this is not the first study to show a disconnect between the microbiology, the Pseudomonas change, and the clinical change. And so that may highlight that we still have more to learn in regards to what's really happening with microbiology in the lower airway, and what are the effects of these antibiotics or macrolides in CF, especially when used long term.
Okay, thank you. Anne, how long would you wait for a patient to be said that they're not responding to steroids before you start a biologic? So is it is there a certain number of courses of steroids? Is it the length?
Right. It really depends on the patient, but I would first say that when we do a trial for steroids, we want to make sure that we're giving an adequate dose. So, making sure it's sort of 1 milligram per kilogram for somebody who you're concerned about ABPA or has severe uncontrolled asthma. Of course, optimizing all of their inhalers, making sure that they're doing them correctly, they're taking them at the right time. We would probably give somebody on high dose steroids a couple of weeks of therapy with the hopes that they would notice some benefit. If they've had absolutely no benefit after 2 weeks of 1 milligram per kilogram, then I think we would reconsider the steroids, especially if that person has had a lot of issues with side effects or they have comorbidities such as CF-related diabetes. and they're not tolerating the steroids very well, then I think we would reconsider. There's no hard and fast rule about how long you should treat with steroids. We've definitely had some patients that we've had to use high dose steroids for a long period of time, and even switching from prednisone to IV steroids to really be certain that the person is not responding to the steroids, because we were worried that they weren't absorbing the prednisone adequately. So, even moving to a trial of IV to see if that works first before thinking about biologics. The other thing to consider too is that biologics don't work immediately. And as you might have imagined, when you're giving something a 4 to 6 month trial to see if it works, obviously you've got to give that time to happen. So sometimes we will start people on steroids, and if they've had lots of problems with severe asthma or ABPA, we might still initiate biologics in the interim with the hopes that we will be able to get them off the steroids in order to give the biologics some time to work, because we don't expect that they're going to work quickly, as opposed to steroids where you do expect that the response is going to be relatively quick. So those are my thoughts on sort of the timing of when you would initiate each one. It is sort of somewhat patient dependent, but those are things to consider.
And what about your experience with these biologics and now with CFTR modulators? Have you had any patients that have been able to come off of their biologics and starting on modulators?
That's a good question. In Canada, we haven't had the modulators, Trikafta in particular, available for very long. So we're just starting to get the majority of our patients, because it was just recently approved by Health Canada. We're just starting to get our patients on biologics. So it's a little bit early to tell the impact that is going to have on some of the patient's symptoms and phenotypes. Our hope is that it will have an impact in the sense that, the asthma phenotype and ABPA won't be as prevalent, won't be as such a major component of their symptoms. But that remains to be seen. I can't say with certainty that's going to be the case, but that's our hope, is that with less inflammation and perhaps, changes in the infection within the lungs, that the asthma symptoms will also be better controlled.
Okay, thank you. Jason, great talk. The progressive defect in the patient on Lumacaftor, Ivacaftor that you presented, do you recall if there was other markers of disease progression in that particular patient?
Unfortunately, I don't for that particular patient. I recall that the FEV1 did go down very slightly. I'm not sure it was clinically significant, but I don't remember the numbers with precision. In general, though, that kind of progression that I showed in that one patient is detectable via imaging and almost completely undetectable via FEV1.
And do you think this type of imaging will have a role then in monitoring progression of lung disease in like post-modulator era?
I do, but only if of course we have something to do about it. Just monitoring progression is of marginal utility unless it makes a change in patient behavior or a change in treatment in the future. And so I suspect that it'll become particularly important as we start to identify individual pathologies and start to treat those pathologies. So just as Anne was talking about with biologics, if airway inflammation and certain airway issues become problematic for one individual patient, then I think imaging can help identify that in a way that could be value added.
Thank you. Anna, given the data you presented about antibiotic susceptibility testing, how often do you check AST?
I mean, I have to admit that I still check it because I still think it's valuable information to know and to have. I think in certain clinical scenarios that I didn't have much time to talk about, but such as, just to name some, sepacia syndrome, it's very important to know, for example, the antimicrobial susceptibility testing. So it's not that I don't look at it, but often my decisions for the antimicrobials that I start patients on are more based on their clinical responses in the past, and also a little bit based on, if they've had intolerances or not. That being said, I do spend a big amount of my time kind of telling my ID colleagues not to specifically switch, for example, a patient from ceftazidime to see something to tizicin just because the Pseudomonas says resistant to ceftazidime. If the patient has done well on ceftazidime in the past, I would rather the patient be continued on ceftazidime this time and give it a chance to see if they get better. So in other scenarios, when the patients become sicker, especially when they go on more chronic kind of IV therapy before transplant, for example, then, sometimes I think I've had situations where I look at the AST more closely just to kind of pick the antibiotic that might be the most effective for the predominant strain that's grown.
And what about in the retrospective review that you showed, like the one from 2021, you mentioned there was no change in outcomes between those that were prescribed antibiotics on AST versus empiric. Were there any negative outcomes in the AST group, like meaning were they on more antibiotics, longer duration, anything like that?
I don't think that there were any negative issues. It's just that they may not have the same improvements as the ones that have been on the other antibiotics. But I do think that is something to keep in mind, like whether if you make your decisions based on the AST, if they have any side effects, I think is also always something that should be considered in the decision.
Okay. And next one is for Dave. Any thoughts on the optimized trial? So this is where azithromycin versus placebo in children with new Pseudomonas were prescribed tobramycin inhaled solution for Pseudomonas eradication.
Yeah, thanks, Sophie. So the optimized study was done in largely younger children, early identification of Pseudomonas with the goal of reducing exacerbation going forward, and a secondary goal of increasing the ability to eradicate Pseudomonas from those cultures. Clearly showed significant ability to reduce exacerbation risk compared with placebo, which is terrific. That effect, reducing exacerbation, has been seen in many studies, virtually all studies of azithromycin. And I think it's a well-proven benefit of that drug, and I am a fan of that drug. There was a non-statistically significant trend toward greater PA positivity in the azithromycin arm in cultures in that group compared with the non-azithromycin participants, but that was not statistically significant. So I don't think it's inconsistent with what we have seen so far. And overall, I think that study showed nice benefit of azithromycin in that population, but no ability to increase eradication rates of Pseudomonas.
Okay, thank you. And the use of Omalizumab, have you run into any issues with getting coverage for it, given the off-label, like you mentioned?
Right, because it's not indicated for CF specifically. It hasn't been a huge problem, primarily because I don't, in the application for that medication or any of the biologics, I'm really not focusing on cystic fibrosis, but really focusing on the asthma component. So I think it's all about wording and how you do these things. But I would say if you're targeting the asthma, which is why you're using it in CF often, then there usually is not a problem in terms of coverage through either private insurance or if there's provincial coverage.
Okay, great. And when patients are on it, are you monitoring their IgE? Like what is can you still use IgE? This would be in patients with ABPA.
Right. Many of the biomarkers haven't been found to be useful markers of response to therapy. And IgE is one of those. So we don't follow necessarily the IgE. And I can think of people who still have elevated IgE levels on Xolair who have had a clinical response. So obviously the clinical response is the most important thing. with respect to symptoms, getting off steroids, pulmonary exacerbations, over and above any serum IgE level. And as I said, I think, in the asthma literature, it's not felt to be a robust biomarker to follow for response to therapy.
Thank you. Anna, is there a concern that oropharyngeal swabs are used to pick up Pseudomonas early in life, even though they're not very sensitive? So when if you were to get a positive swab and, the child is asymptomatic, do you act on that?
Yeah, that's a very important question. Thanks for asking that. So in my experience at the different centers that I practiced at least what I saw is that, yes, when young infants are found to have Pseudomonas on an oropharyngeal swab cultures, they will usually undergo eradication. And I think the reason for that is that we do try to eradicate early or new onset infections in young infants because it can have negative impacts later on, right? If it becomes chronic. So I do think that for the most part, when it's found, it tends to be considered a positive, and the young infants tend to be treated with eradication treatments.
Thank you. And let's see, this is for actually, Anna, again, what are your thoughts on the STOP trial results regarding shorter IV antibiotic duration in select patients?
Well, I do think that we can't kind of deny that scientific evidence if it does show that it may be an effective, option to treat patients. I think it's something that's important to consider. As I mentioned, I do think that stewardship will become more and more important in everything, but including in CF care. So certainly if we have strong scientific evidence that shorter duration or even, single coverage for certain pathogens may be proven to be safe and effective, I do think that there may be changes and, recommendations towards that, because certainly what we know is that in order to adhere to the best stewardship principles, the shortest duration with the right antibiotic at the right dosage and for the right bug is usually what we go by. So I do think that the more evidence we have, such as the evidence from the STOP trial, the more we can have formal recommendations to follow for shorter durations, for example.
And in the era of antibiotic stewardship, Dave, with highly effective modulator therapy, do you think there'll be a role to discontinue azithromycin altogether, given the reduction in exacerbations?
Yeah, it's a good question. I think Hussein, thanks for that. So I think that's a possibility, right? We don't want to use any drug that's not beneficial, but I don't have any evidence, and I don't know of any data suggesting that that's the case, even in those on highly effective modulator drugs. Most of the studies, at least up front, looking at withdrawing therapies or simplifying regimens, have prioritized therapies that have been identified as burdensome by the CF community, and azithromycin is not one of those. We did ask that a few years back, and it was near the bottom of the list in regards to overall burden. It's obviously inexpensive, it's relatively safe. So for some reasons, it may not be at the top of that list, and it may take some time and some care to try to figure out whether or not there is ongoing benefit in those on hemp. So yes, there may be some role for considering this, but that study I don't think would be very easy to do, and it's not seen as highly burdensome. So I doubt it gets prioritized as a big trial up front for feasibility and lack of burden concerns.
Yeah, I guess for patients, it'll be more interesting to see for them if they can stop the inhaled antibiotics, the, mucolytics and so on that are a bit more time consuming. Jason, I was wondering if you've done the research you did was in lumacaftor, ivacaftor, when you were looking at the difference in imaging. Have you done this with triple combination therapy? And if not, is that something that you plan on looking at?
We have two trials underway now. So one in older kids, 12 to 18. It's a multi-site trial for Trikafta to demonstrate the treatment effect. And the other one is for children who are just turning 6. So one is High Point, the other one is called Beginning, and that's an add-on to the Begin study, which is a larger national study.
And any this preliminary results?
I'll say that in individual patients, we certainly see a treatment effect. This is, a more serious trial. And so the analysis is fully blinded and I can't, won't have any final results, but it's very obvious that there's a treatment effect, yes.
Okay, thank you. And I think we have time for one more question. With respect to oral antibiotic of mild to moderate exacerbation, so this question is going to be for Anna. How does AST impact your decision making? So do you predominantly treat with broad spectrum versus target bacteria, xenon cultures?
Yeah, that's a good question. I haven't come across much evidence about, AST specifically for orally treated events. And I think there's, in general, maybe a little bit less published about, orally treated exacerbations, at least. I do think that I applied the same principles for the milder events that are treated with oral antibiotics as for the ones treated IV. So usually I don't necessarily go broader. A lot of what we see for children is, for example, when they have Staph aureus, and then we will pick, for example, cephalexin orally. I will try to be consistent with whatever the patient has responded best to. But on the other hand, I don't necessarily stick to the AST results. I do use some common kind of ID principles of what I think is the best coverage for the type of bug, however.
Okay, well, I'm going to end it there. Thank you very much to our speakers, and thank you for all the great questions. Hopefully you guys enjoy the rest of the conference.
Thanks, Sophie. Thank you, everyone.
Thank you.
Thank you.
Thank you so much.